Hello, everyone, and welcome to Let's Talk About It, Taboo Topics in Parkinson's. We're so glad you're here with us today. I'm Sarah Osborne, Associate Director of Community Programs with Parkinson's Foundation. And here with me today are my wonderful colleagues, Kayla Mead, Jenna Lennon, and Rachel Hausman. I'm based in Los Angeles County here in California. So the chat is open. You'll find that chat icon. It looks like a speech bubble in the bottom black bar of your screen if you're joining from a computer. If you're on a tablet or phone, you might have to tap the more icon. It looks like 3 dots, and then you choose the chat. And we'd love to hear from you. We hope you'll use that chat a lot today to talk to us. We'd love to know where you're tuning in from. So tell us if you're in Sacramento, maybe you're north in Redding, maybe you're around the area in Stockton, Modesto. Tell us where you're calling in from. Okay, and while we're hearing from our audience, we would like to thank our program sponsors, Boston Scientific and Abbott. We want to thank them sincerely for their support of this important topic today, and we invite you to learn more about them at the link that we are going to share in that chat. Okay, so let's do a quick poll. Let's see, let's find out what everyone likes most about learning online. So you'll see a poll up here and it says, what is your favorite thing? What are your favorite things about learning online? So go ahead and choose whichever one most applies to you. And do we have results for that one? Great. So getting the latest, newest information and hearing speakers I wouldn't normally get to hear. That's great. Thank you so much, everyone, for sharing that. Okay. A little bit about the Parkinson's Foundation. The mission is to make lives better for people living with Parkinson's today until there's a tomorrow without the disease. And we fulfill our mission through what we call our 3 pillars, which are better care, research, and education and advocacy. So we provide free resources, including our website, which is parkinson.org, our educational book series, which some of you may have, of course, webinars, podcasts, our hospital safety kit, which is called Aware and Care, and our newly diagnosed materials. We also have a toll-free helpline, 1-800-4PD-INFO. The Parkinson's Foundation newest research project is called PD Generation, and this is a no-cost at-home genetics test, and it's for people who have a confirmed Parkinson's diagnosis. So we're going to share that website and the information in the chat, but I also wanted to let you know that we have a link today that will set you up with an appointment. So if you're like, yes, I have a confirmed diagnosis, yes, I would like to receive the free test and the free genetic counseling, you can go ahead and click that link, sign up for an appointment, and we'll get you set up with a free PD generation test. We have another study going on right now. It's called Topaz. It studies bone fracture prevention. And if you'd like more information about that, you can call us at the 1-800-4PD-INFO number. Okay. So we do hope that you will stay connected to us on our website, social media channels, and by phone and email through our helpline. We have a couple fun things going on in Sacramento. So I wanted to invite Jenna Lennon to the screen to tell us about them.
Hi, everyone. Thank you so much for being here. We have our upcoming Moving Day Walk on May 21st at American River College in Sacramento. It's a great day for the community. We'll have a lot of fantastic exercise demonstrations and, of course, sponsorship and resources for you to learn all about everything that Parkinson's Foundation has for the community. And then we have our Parkinson's Revolution event, which is an indoor cycle event coming up on June 11th at Team Ride in Sacramento. So I hope you will join us, and you can find out all of that information in the chat and movingdaysacramento.org and Parkinson's Revolution Sacramento. Thanks so much.
Great. And of course, Jenna is here in the meeting today. So if you have any questions, go ahead and message her. I'm sure she'll help you out. So a few quick housekeeping items. We encourage you to submit those questions using the Q&A or the chat. Keep those questions coming. We will go through them at 11:15. So stay tuned until 11:15 to go through the Q&A. We are recording this meeting, which you probably saw when you came in. We're going to share the link to the YouTube video after the event. So if you missed something, no worries. You can always go back and look. We have a fantastic program lined up for you today. We're going to talk about taboo topics in Parkinson's disease, including behavioral changes and estate planning. So let's get started. I'm happy to introduce our first speaker. As a movement disorder neurologist, Dr. Malhado-Chang has focused her training on the diagnosis and treatment of conditions such as Parkinson's disease, focal and generalized dystonia, tremor, restless leg syndrome, and Parkinson's plus syndrome, such as multiple system atrophy and progressive supranuclear palsy. She also specializes in the use of deep brain stimulation and Botox injections for a variety of movement disorders. Welcome, Dr. Malhado-Chang.
Thank you, Sarah. All right, I'm going to go ahead and share some slides. All right, can everyone see that okay? Great. Okay, so thank you so much, everyone. My name is Norika Malhado-Chang. I am a professor of neurology at UC Davis in Sacramento, California. I welcome all of my family of patients, friends. Thank you so much for joining us. I am a movement disorder neurologist, which means that I dedicate my practice mostly to Parkinson's disease and deep brain stimulation. I feel very qualified to talk about this particular topic because I live these things every day, not just in my professional life, taking care of people with Parkinson's, but also in my personal life. As many of you know, I have my mother with very, very advanced Parkinson's disease. I actually diagnosed her myself in 2001, so just over 20 years ago, and my father-in-law with PSP, progressive supranuclear palsy, which is a related condition similar to Parkinson's, a little different. But because, and when I'm not working, I'm taking care of my mom. And so I am very familiar with these types of really challenging symptoms and what it's like from the caregiver side, as well as from the science side. So I hope I can share some of these things with you today. I am so grateful to the Parkinson Foundation for creating this series of taboo topics because nobody wants to talk about cognitive changes and hallucinations and psychosis and things like that. But it's important. It's important because knowledge is power when it comes to Parkinson's. And I hope that this kind of inspires you to talk to your doctor about symptoms if you're experiencing any of these yourself. So first, I'll start off with what kinds of behavioral changes we might experience in Parkinson's. We'll talk about mood changes, personality changes, cognitive changes, and then we'll get into some of the topics that are really taboo, and that's psychosis, right? Hallucinations, paranoia, some compulsive behaviors. And then finally, I hope we can end with some strategies, tips, and tricks for how to maximize quality of life, even in the presence of these really challenging symptoms. First, we'll start off with mood. Specifically, I want to focus on depression and anxiety. These symptoms start in a very subtle way. And sometimes the initial changes are really just a change in personality. And those personality changes are often more noticeable to the spouse or to the family than the person themselves. And it might just start with being more passive, or it could eventually turn into some loss of motivation for things that have normally been they've been passionate about. And as the disease progresses, that could even turn into something called apathy. Apathy is where there's a loss of interest or initiative, the drive to do things. And that could lead to restriction in activities or even less inclination to talk. And a typical example is somebody who used to be sociable might start to lack the desire to socialize with friends and prefer to stay home. That was convenient in the era of the pandemic, but that's not always normal. And so I'd like to spend some time talking about these things. Apathy sometimes is confused with depression. So let's talk a little bit about depression. Depression is low spirits, lack of interest, bleak outlook, and it's really, really common. At least a third of people with Parkinson's exhibit significant symptoms of depression. And depression is very serious because it's a predictor of more impairment in activities of daily living and an increased need for symptomatic therapy in Parkinson's. As I mentioned earlier, because it involves a loss of interest, sometimes it's difficult to differentiate from apathy. And social isolation is a risk factor for developing depression. And we surely saw a higher rate of depression over the past 2 years with social isolation. What are the causes of depression in Parkinson's? The first is pretty obvious. It could be a reaction to having the diagnosis in the first place. But the other two, I would argue, are even more serious. And that's first neurochemistry. So an imbalance in neurotransmitters, or the chemical messengers in the brain, can absolutely cause depression. And that specifically involves serotonin, norepinephrine, and dopamine. The other involves the person's perception of their handicap. And I really want to emphasize perception because our studies have shown time and time again that it actually doesn't have to do with actual disability at all. It's the perception of one's handicap that leads to depression. And why is recognizing depression so important? Depression has a major impact on motor symptoms. It actually worsens cognition, and it can actually worsen overall disability. So I just mentioned how your perception of disability can cause depression, but then depression can actually lead to real disability. So it's very serious, and it's very important to recognize early and address. And the best part is that treatment is available, and treatment can improve mood, treatment can improve mobility, and overall quality of life. It takes a lot of courage to talk to your doctor about depression, but I encourage you to do so. It makes a big difference. The most common treatment that we use with regard to medication is the selective serotonin reuptake inhibitors. This is quite well tolerated group of medications. There are some side effects, like with any medications. Serotonin syndrome is very, very rare, but it's important that when we start any of these, when we start this category of medications, that we watch for it. And sometimes you might want to work with a psychiatrist along with your neurologist to co-manage and help with dosage adjustments. Counseling and cognitive behavioral therapy are also really important. And sometimes it's that combination of the medication and the therapy that really is the most effective. The flip side of the depression coin is anxiety. And anxiety and depression often coexist. They often feed off of each other. Sometimes it's difficult to recognize that anxiety is brewing in the background. It could just be a loss of confidence. But it's tricky because as anxiety progresses, it could include a fear of social occasions. And then worst case scenario is a tendency to withdraw. And as I mentioned before, social isolation worsens the depression and the anxiety further. So it becomes a vicious cycle. So it's important to nip in the bud. 2 out of 5 people with Parkinson's will experience anxiety, and it comes mostly in 2 forms. One is a generalized baseline anxiety where there's just a constant worry in the background and some recurring fearful thoughts. And the other is an anxiety attack, or sometimes called a panic attack. And that's when you have the racing heart, the trouble breathing, some sweating, tremors. And those are very scary because they can feel like you're having a heart attack. And people often have both of these things. And what causes them could be a whole number of things. As I mentioned with depression, anxiety is often triggered by one's perception of how others might see their diagnosis, or perception of their change in mobility or their loss of independence. Again, it's not necessarily the actual loss of independence, but it's the perception that triggers that anxiety. And the neurotransmitter imbalance that I mentioned earlier also underlies anxiety. So there's absolutely changes that are happening on a neurochemical level as well. And I put a note here that anxiety and stress worsen tremor. So many of you may have experienced that already, that sometimes managing the anxiety in turn manages your tremor. Here are some tips that I share with my patients. I hope it will help you as well. The first is to be flexible. Life is unpredictable, particularly with Parkinson's. And so it's important just sometimes to stop and give yourself some grace. Recognizing your triggers. So sometimes anxiety is consistently triggered by the same issues, and recognizing what those are might help. I have some patients who have told me that every evening, I start to feel my heart racing and start to feel uneasy. And it wasn't until we realized that, that's usually when you watch the news, for example, and that the news just unconsciously was a trigger for anxiety. And so addressing those can go a long way. Pay attention to whether or not your anxiety is related to your Parkinson off times. So when your medications are wearing off, that can trigger some anxiety. And if that's the case, talk to your neurologist, because maybe an adjustment in your Parkinson medications can help. And if they're not related to your off times, maybe it might be time to treat the anxiety itself. And anxiety is treated like depression with a multimodal approach. That includes both medications and counseling and cognitive behavioral therapy. The medications that we use for anxiety are conveniently very similar to the medications that we use in depression. Those SSRIs that I mentioned earlier are very effective as an anti-anxiety. There's also sedatives like benzodiazepines. I don't use those as much, only because I'm concerned about the effect of sedatives in Parkinson's, like confusion, imbalance, etc. But for some people who are experiencing very severe anxiety, they can be a lifesaver. Some other tips that I have are managing anxiety in your own way, in the types of activities that speak to you the best. I'll tell you, for me, if I want to really take my anxiety down, I take my dog for a walk. Pets, animals, exercise, sunlight, being outdoors, that's what works for me. But for other people, it could be acupuncture or massage or participating in their Parkinson support groups, or maybe using some relaxation techniques. So it's important to be flexible and try new things. If you haven't tried some of these things before, they could really help. Next, we're going to shift gears a little bit and talk about cognition. Cognition involves the trouble with thinking. And as a neurologist, I'd like to share with you how complex the thinking is. Thinking encompasses so many different skills, actually. So let me give you an example of some of those. Some of the cognitive challenges could include distractibility, disorganization of thought, slowed thinking. We call that bradykhrenia, and that's a delay in mental processing speed or delay in memory retrieval. I can't think of the word, but give me some time and it'll come to me. Trouble finding the right words. Our technical term for that is impaired verbal fluency, kind of tip of the tongue phenomena. Trouble planning and accomplishing tasks, trouble multitasking. This is a big one, right? It's the difficulty handling multiple tasks at the same time. Things that you used to be able to do all at once, now we have to do separately. Difficulty focusing one's attention, difficulty concentrating on a task, trouble making choices. So something as simple as a menu in a restaurant becomes overwhelming because there's too many choices. And then there's memory loss. Cognitive issues are nearly universal in Parkinson's. They gradually develop over time. So cognitive changes never happen out of the blue suddenly. And if they do, then it's usually due to something else, not the actual Parkinson's disease. Why do we have cognitive changes in Parkinson's? One is changes in the brain itself. So there's specifically dysfunction in the frontal lobe, and that controls executive function. And then there's also changes in neurotransmitters. So again, those chemical messengers like dopamine, acetylcholine, and norepinephrine, those changes underlie cognitive impairment as well. Stress contributes to cognitive impairment. Poor sleep, depression. There's a spectrum. Obviously, it starts very mild, and when the issues don't really interfere with your life, they're there. You know, maybe there's some word finding difficulty or maybe some trouble with multitasking, but you're still able to do all the things that you need to do. We call that mild cognitive impairment, or MCI. But on the other end of that spectrum is dementia. And we'll talk about dementia a little later, but that's when there is interference in activities of daily living. How do we diagnose cognitive impairment? Number one, we have to talk about it with your doctor, and typically your neurologist will do an interview and an examination. Some of you may have experienced that already, where your doctor has asked you questions like, remember these 3 words. I'll ask you them again in 5 minutes, or draw a picture for me, or testing your vocabulary or calculations. Those usually take just a few minutes, but it gives your doctor a good sense of whether or not it might be worthwhile to do formal cognitive testing called the neuropsychological evaluation. Those tests are typically conducted by a neuropsychologist, and they're very lengthy. They're very comprehensive. They might take up to 3 hours, and they're lengthy because they give us a huge amount of information that helps to differentiate your cognitive impairment from maybe other things like Alzheimer's disease or stroke or depression. So talk to your doctor if you think you have some mild cognitive impairment, because there's some basic steps that we need to take to see if anything is treatable. First of all, let's screen for some reversible causes of cognitive impairment. Wouldn't that be nice? There's some basic labs that we can check. I always check for things like blood counts and blood chemistries, thyroid function, B vitamins. Sometimes there's other medical issues that could be contributing. Next, I screen for depression and anxiety. As I mentioned before, depression can slow cognitive processing and can even cause a type of dementia that we call pseudodementia. So if depression isn't present, it absolutely should be treated. Next, I review all the medications that are being taken because certain medications can contribute to cognitive slowing. Some of those might be pain medications, sedative medicines, anticholinergics, amantadine, dopamine agonists. So reviewing those medications in the setting of mild cognitive impairment is critical. And then I assess sleep. Because as I mentioned before, poor sleep worsens your thinking. So it might even be indicated to do a sleep study to rule out some of these other sleep disorders that are also very common in Parkinson's. What are some of the steps that we can take when cognitive impairment is mild? The first is cognitive rehab. There's a type of therapy that helps your thinking. Just as physical therapy, you might be familiar with physical therapy, exercise that helps your mobility. There's cognitive therapy that also helps your thinking. And that's best earlier on. It's harder with dementia because it involves a lot of insight into one's own challenges and following instructions and things like that to do these exercises. Next, make lists, write things down, keep a routine. Clearly structured daily schedules help a lot because there's less variables being thrown at you during the course of the day. Medication timing gets really hard, and that would be hard for anyone. With Parkinson's, your medications are sometimes dosed multiple times per day. So keeping pill boxes and pill alarms to stay on track with your medications really helps. What's challenging is that because some of these medications can contribute to your cognitive clouding, if you double up on them or take them at the wrong times, it could make things even worse. Increase opportunities for socialization. Socialization is one of the single best things that you can do to exercise your brain. And it may not seem like it makes that big of a difference, but we did see a lot of that impact during the past 2 years with the pandemic. So if there's an opportunity for you to socialize with people outside your regular household, take them. Exercise. We have data that exercise helps your thinking. So even more reason to exercise. Avoiding low light situations. We want to get as much of our senses stimulated as possible, and divide tasks into manageable segments. As I mentioned before, with multitasking being a challenge, dividing your task up into small manageable parts can make things a lot less overwhelming. Next, let's talk about Parkinson's disease dementia. Dementia is a concern when 2 or more of the cognitive spheres that I mentioned earlier are affected. So remember, cognitive spheres could be things like memory, language, visuospatial function, decision-making. So 2 or more of those are abnormal, and when those impairments interfere with your daily life. According to the Movement Disorder Society, Parkinson's disease dementia is characterized by impairment in attention, memory, executive and visuospatial functions, and behavioral symptoms such as affective changes, hallucinations, and apathy are also present. What are some of the behavioral disturbances? 1, verbal and physical aggression. And this is when we realize that this is completely unintentional. This is part of the disease talking here. Wandering, agitation, maybe some inappropriate sexual behavior, uncooperativeness, or urinary incontinence. How do we manage dementia when those behavioral disturbances are part of it? That becomes challenging. And the top thing that I tell my patients is structure. Keep your day-to-day activities as routine and regulated as possible in a familiar environment. Moving into a new place is everything is very overwhelming and different, and we may not remember where things are, and that can accentuate some of the behavioral disturbances in dementia. This also gets challenging for the care people, and so bringing in home assistance and caregivers is really recommended. I know that's challenging. It's difficult to take the first step with that, but trust me on that, it goes a long way when there's behavioral disturbances. Simplifying your medication regimen and eliminating any unnecessary medications. Treat the depression. And sometimes medications can help. The medications that you may have heard of are things like donepezil, also known as Aricept, quetiapine, rivastigmine, or memantine. And then I also put on here self-care for the care partner. Dementia with behavioral disturbance is often more damaging for the care partner and the loved ones and the person themselves. So it's really important that we shift our attention and actually make sure that the care partner is taking care of themselves as well. Compulsive behaviors might come into play, and I want to tell you a little bit about what some of those compulsive behaviors might be. Pathologic gambling, this has been famous in the news, so you may have heard of that. Hypersexuality, compulsive shopping, and spending money, buying things. Binge eating. Binge eating means eating with loss of control and gaining weight. And dopamine dysregulation disorder. So dopamine dysregulation is really where there's repetitive behaviors. One example could be excessive use of the computer or excessive cleaning, even when things are already clean, to the point of being disabling. A lot of these repetitive disorders or repetitive behaviors are on the basis of dysregulated dopamine in the brain. They typically occur at nighttime with a renewed energy and a renewed mobility that they might not have during the daytime. How do we manage these compulsive behaviors? It's really hard. The safety is top priority. If there's medications that could contribute to compulsive behavior, it's important that we try and limit those or discontinue them. The most implicated is a dopamine agonist category of medications. So things like pramipexole, ropinirole, rotigotine, they're wonderful medications earlier in the disease, but because of this potential complication, if somebody with dopa dysregulation or compulsivity are on these medications, it's probably a good time to transition off of them. And antipsychotic medications like quetiapine could be helpful with managing some of these compulsions. Next, let's talk about psychosis. Psychosis is probably the most taboo topic of them all. And I want to dive right in. Let's talk about hallucinations, delusions, paranoia. Basically, loss of touch with reality. And that loss of touch could come in the form of visions. So you can have illusions. You can have a false sense of presence where you feel like somebody is in the room. You look and there's nobody there, but you just feel it. Hallucinations are when you see, hear, or feel things that aren't there. And delusions are when you think things that aren't rooted in reality and you have a fixed idea about something. One example of that that's very common in Parkinson's is paranoia. Paranoia is a fixed fear that either people are out to get you, that your privacy is being compromised, your safety is being compromised, or jealousy with infidelity. It's classic in Parkinson's disease, where there's a paranoia of infidelity in the spouse. Parkinson's disease psychosis is very complicated. It's related to the disease itself. It is related to the medications you take for the disease itself. And it can also be exacerbated by other medical problems like infections. A urinary tract infection, believe it or not, can have devastating effects in terms of hallucinations or delusions. The good news about that is that that part is treatable. Similarly, metabolic disturbances, so an abnormality in your blood chemistry, for example, can precipitate psychosis. I have a picture of a cat here. A cat is one of the more common early hallucinations. The hallucinations are typically visual. They're not typically auditory or tactile as people might experience in other psychiatric conditions. So it's often seeing things that aren't there. Often, if you, for example, see a person or an animal, they don't say anything because we don't have the auditory part of the hallucination in Parkinson's. They could start out very minor, and so they could be, like I said, cats or familiar people. And in the beginning, insight is preserved, which means that the person experiencing knows that they're not really true, knows that they're false, knows that their mind is playing tricks on them. The next stage we call benign hallucinations. That's when the hallucinations are kind of benign things like children or animals, and they're generally non-threatening. But the person who's seeing them feels that they're really there. And unfortunately, those can progress. They don't always progress, but they could. And this is where I feel they need to be treated. When they get to this advanced stage, and I've listed them here as malignant hallucinations, where the hallucinations get frightening. And that could be menacing people in the house, or, delusions, or paranoia that involve your medications being poisoned, for example, and then not taking your medications because of that delusion. Those get more dangerous, and it is critical that you talk to your doctor if you're experiencing any of these. My approach to managing the hallucinations is searching and treating for any type of illnesses, limiting medications that can exacerbate hallucinations. For example, sleep aids. Again, I mentioned the dopamine agonists, anticholinergics. If levodopa can be decreased, we'd like to try and consider that. And then trying antipsychotic medications may be necessary. The most common ones are quetiapine, clozapine, or pimavanserin. Donepezil is a medication I mentioned earlier with dementia. This is a dementia medication, but in Parkinson's, it helps with the hallucinations as well. Engaging in activities, avoiding idle time, that's usually when the hallucinations come, and treating depression. I put a note here that it often becomes a very challenging medication balance to strike. And, on the one hand, the levodopa is necessary for mobility, but then on the other hand, it could be worsening the hallucinations. How do you strike that balance? What I do is, my mantra is that intact mental function is always more important than intact motor function. So always lean on the side of treating the hallucinations. Here's some do's and don'ts. Care partners always ask me, how do I manage the hallucinations? I can help them with their walking. I can help prepare meals, but how do I help when there's a hallucination going on? What I recommend is don't argue that the hallucination is not there. That rarely works, and it usually just increases agitation and frustration, because for the person who's experiencing the hallucination, they are there. And so for their care partner to argue about it, I think is counterproductive and often makes the person feel more alone. So I think what is important is validating the experience and providing empathy and support and reassurance that they're safe. So as I've mentioned, there's a lot of things outside of Parkinson's itself that impacts quality of life. We talked about hallucinations and delusions and cognitive impairment. The three most important things and the three things that we can probably have the biggest impact on changing that affect quality of life is mood, sleep, and the sense of agency, the sense that you're in control and the sense of independence. And you are doing those things purely by being here and expanding your knowledge and understanding of Parkinson's. And it is a collaborative effort. It's a collaborative effort with your partner, with your care team, and with community partners like the Parkinson Foundation. We are here to help. So that's it. Thank you very much for your attention. We'll take questions, I guess, a little bit later.
Thank you, Dr. Malhado-Chang, for that really informative talk. That was a lot of fantastic information, and we had a few questions come in. I did want to just point out that the topics, we also have books for those topics. You can order them from our helpline. We have mood, which covers depression, anxiety, apathy. We have cognition, and then we also have a book on psychosis. So just wanted to point these out. And we do have a few really good questions for you, Dr. Malhado-Chang, when we come back to the Q&A. So thank you so much. Okay, so I'm excited to introduce our next presenter, Melissa Tafoya. So we just heard how important exercise is for our brain, including our mood and including our cognition. So I would love to invite everybody to join us. Melissa is a National Academy of Sports Medicine certified personal trainer, corrective exercise specialist, TRX suspension certified, Rocksteady boxing certified, and she has started the first affiliate program in Sacramento for Rocksteady boxing. Her most recent endeavor is a new business. Melissa, maybe you can tell us about that. Welcome, Melissa.
Hi, guys. Thanks for having me. Good morning and happy Friday. Yes, as Sarah was saying, we have a new facility here, Hope in Your Corner, and that's where my private clients and my Rocksteady boxers come. It's our safe space, our sanctuary to get stronger together. So really grateful to be with all of you today and excited to really boost our moods and our spirit and some movement. But I first just want to show my gratitude and appreciation to the Parkinson's Foundation and our phenomenal support and resources that we get from them every day. Today is a great example of that. They continue to be a bright light in our pipeline of support here at Hope in Your Corner. And brilliant specialists such as Dr. Malhado-Chang have just been instrumental in our fighters' support and care here in Sacramento. So if you're ready to get started with me, I'd love to have us warm up with some power moves, and then we'll get into our boxing. So a little bit of everything, a nice little buffet, if you will. Just make sure that you have enough space, maybe arm span around you that's clear of anything on the floor, any obstruction, so you can move freely. If you choose to sit, that's great. We will start with some seated power moves, and then I will give you the option to stand up. So anything you'd like to do, you're free to jump in any capacity. So if you're ready, let's do this. We're going to start on the edge of our chair and just sitting up nice and tall, okay? We're going to talk about a power up, and we're going to get really like animated and loud, okay? So as loud as you're comfortable with. We're going to get our hands on our thighs, and we're going to make a nice clapping sound, and this is going to be our ready position, okay? Hands on our lap, leaning forward, ready. When I say power up, we're going to sit up tall, and we're going to sit and clap the sides of our chair, really pulling our arms back, okay? Ready, power up. There we go. Ready, power up. Ready, power up. Ready, power up. And one more time, ready. When we power up, open that chest tall, proud, and fierce. Right on, everybody. So we're starting to get that blood pumping, starting to feel better already. We're doing this together. We're going to move into the power rock. And what I want you to think about is bringing one leg and just kicking it out, okay? One leg kicks out. The opposite side, you're just going to lean. You're going to rock to the other side, the other thigh, and with big hands, reach up as high as you can. If that's down here or up here, whatever feels good, reach up and look up. Come back to that ready position. Other leg comes out, big hand reaches up, rocking up, and ready position. All right, guys, let's reach for the stars. Kick out and reach up, ready, kick out and reach up. Does not have to be perfect. We're just feeling good. Eyes following our hands. Ready, rock and reach up. Ready, rock and reach up. And ready, rock and reach up. One more time, guys. We're going to reach for the sky. Ready, rock up and reach. Very nice. Coming back to center. Do the best you can in any of these movements. If you can just turn and reach, that also works. We're going to do the power twist. So now, ready position here. We're going to open wide with big arms. If you can, we're going to twist and clap our hands together to the left or right, doesn't matter. Then we're going to open wide, ready, and twist and clap to the other side. Turn as far as you comfortably can. Open, twist, open, twist, open, twist, and open, twist. Two more times. Open, twist, open, twist, and back to that ready position. How we doing, gang? Pretty good? All right. So the last power move is the power step. With the power step, our feet are together, okay? We're going to clap our thighs and lean forward. One leg is going to step over to the right or left, and that same arm is going to punch, all right? When I say ready, we come back in, and you just step however you can to the side, alternating. So we're going to go to one side and punch. Ready and power step. Ready and step. Ready, step. Ready, step. Couple more. Ready, step. One more time. Ready, step. And come back to center. Very nice, you guys. Now, often we're perfectionists and we're trying to make everything perfect. Right now, I want you to move to where it feels good. Doesn't have to look like me or anybody else, just your movements that feel good, okay? If you'd like to join me standing, we'll do this one time through. Standing, you can also stay seated, all right? If you're standing, make sure that your chair is away so that way you have nothing to trip on. Got enough space around you to stand nice and tall, okay? Feet are about hip width apart. We're gonna squat down like we're reaching for that imaginary chair. We're gonna clap our thighs, and when we power up, we're gonna bring our arms to our side and clap the side of our legs. So a lot of engagement here. Ready, squatting down, power up. Ready, power up. We're gonna bend those knees in that ready position and power up. Good, and ready, power up. Very nice, you guys. Now we're going to reach for the stars, that ready rock. So that wide stance, I want to shift my weight to the right side and turn to my right and reach up as high as I can to maybe the right corner of my room. Look that way. Come back to that ready position and turn to the left. Ready, rock to the right. Ready, rock to the left. And as long as you're alternating, it's fine. Ready. To the right, ready to the left. Two more times. Ready to the right and ready. Get big to the left. Very nice, guys. We're coming back to center, just shaking it out a little bit. Standing nice and tall again. Power twist, opening up nice and wide. We're going to twist to the left and clap our hands together. Ready, twist to the left. Ready, twist to the right. Ready, twist to the left. Ready, twist to the right. Ready, twist to the left, and ready, twist to the right, and ready. Open that chest and big open hands. You're embracing the world. Very nice. Now bring your feet together. And if you can, we're going to step to the right with that power step. We're starting to transition into some boxing too. So if our hands are up and we step to the right, we're going to punch out to the right and come back to center, and then step to the left and punch to the left, back to center. Reach with that punch to the right and step back to center and to the left and back to center. Are you with me, guys? 4 more. Ready, punch to the right and step. Ready, punch to the left and step. Ready, to the right and step. Ready, to the left and step. And back to center. Very nice, everybody. Looking good. So I want to leave you with a couple pieces of self-defense with your boxing. If you'd like to join me, again, you can do this seated or standing. If you need a sip of water, we've been doing a lot in a relatively short amount of time. Go ahead and grab your chair, and you can do this either sitting down in that split stance with your elbows tucked in, or you can stand up in that fighting stance. And a fighting stance just means our feet are hip width apart, and we take that right foot back, and our elbows are tucked in nice and tight, okay? Either way, we're shifting our weight front to back. Our guard is up, and we're protected, okay? With this good protection, I want you to twist and throw your left hand out there. That's your jab. I want you to twist and throw that right hand out there. That's your cross. Back to your position with your guard up. We shift our weight front to back. That's our boxer's bounce. That means we're secure. We're ready for anything. The same thing can happen sitting down. You shift your weight front to back. You're protected with your guard, your shield, and you're sturdy, shifting front to back. Ready, guys? We're going to throw that 1 and 2. 1, 2, boxer's bounce. Ready? Let's snap it out there. Jab, cross, boxer's bounce. Also known as our 1 and 2. 1, 2, boxer's bounce. 1, 2, boxer's bounce. 1, 2, boxer's bounce. 1, 2. So all that twisting we did with the power moves, this is perfect for your boxing. You're going to turn your hips with that jab, with that cross, and come back to that bounce. So I want to leave you with 10 hard punches, okay? You're going to snap your punches out as far as you can with that good twisting. Get all that circulation in your arms, and also protect yourself. Keep any danger or threat at bay. Are you ready, gang? Can we do this? 10 hard punches. We got to breathe hard with this. All right, let's do it. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Very nice, everybody. Drop your hands, bring your feet together, shake it out. Job well done. I'm telling you, if you can hold that stance and keep that guard up, that's half the battle. You're here making change. Thanks for having me this morning.
Thank you, Melissa. Thank you so much. We're going to share some of Melissa's information in the chat too, if anyone would like to reach out to her. I feel better already, so thank you for that. Okay. All right. I'd like to welcome our next presenters, Mark Schumacher and Juliette Robertson. Mark earned a bachelor's degree in business administration from the University of Arizona in Tucson and received the CFP, AAMS, and CRPC designations. He joined Edward Jones as a financial advisor in 2008, opened an office in Lincoln, California. And so let's see. He served in various roles in the firm, including client solutions leader, recruiting leader, financial advisor, coach, and mentor. Ms. Robertson started her legal career in healthcare litigation and hospital administration, which has been integral to her success in estate and special needs planning and litigation. She began working in trusts and estates in 2010 and joined Therese Adams at Adams and Hayes Law in 2013 and succeeded Therese Adams as the owner of the firm and earned her certified specialist status in 2015. Welcome.
Well, good morning, everybody. Thanks for being here this morning. I want to first start off and just say thank you for all the hard work that everyone is doing for the Parkinson's Foundation. My connection to Parkinson's is through my dad. He passed away in 2020, but he lived with Parkinson's for 16 years. I also had an uncle who had Parkinson's. And as a financial advisor, I have a lot of clients that are living with Parkinson's. So you're going to hear me speak today from the lens of a financial advisor, but also from the lens of a family member who's lived with somebody with Parkinson's. Joining me today is Juliette Robertson, an attorney that I work with locally here in Lincoln. I am not an attorney, so I cannot give legal advice, but we work with clients in their situations enough to see opportunities where estate planning becomes important. So let's kick it off. So when it comes to estate planning, it's not just an attorney. We like to look at it as a team approach. If we were to compare it to those living with Parkinson's, they have a healthcare team, which involves multiple doctors and multiple people on the team. When it comes to estate planning, we have a financial advisor, a CPA, and an attorney, and each of us bring a unique set of skills and expertise to help our clients. As a financial advisor, we work with the investment sides, portfolio allocations, understanding risk, and helping avoid that. A CPA is going to help with the income tax planning, wealth transfer, as well as any tax implications. And then lastly, the attorney really helps to advise on what type of legal or estate planning goals need to be put in place. So to give you some insight on how important estate planning is, as financial advisors, we look at 5 primary financial needs. One is preparing for retirement, so helping people get there. 2 is living in retirement, making sure that our clients live successfully throughout their retirement and don't run out of money. Paying for education, planning for the unexpected, and then last but not least is planning your estate or inheritance. We have 5 key steps that we look at when it comes to financial success, and I think that they apply to estate planning success as well. So one is understanding, where are you today? What does your current plan look like? And through evaluating that, understanding where it is that you want to be. What are some of your goals? 3 is understanding, are those goals realistic and practical? Can we get there? If so, 4, how do we get there? What type of documents do we need? What type of investment strategy do we need? And then lastly, how do we stay on track? Life throws us curveballs. And so through periodic reviews of finances as well as estate planning, we can make sure that those goals remain on track. All right, so I'm going to jump through a few slides here in the interest of time. So quick fact, everyone on this call has an estate plan, even if you haven't taken any action at all and created your own. The great state of California, which it sounds like most of the people on this call are here, the state of California has a plan for you if you don't. The question I would ask is, does the plan, or does that plan actually reflect your wishes? Wishes vary from family to family. And one of the things that changes or can impact the complexity of an estate is how much control one has. Some of the common estate objectives we look at is asset transfer. So helping make sure that assets go where and how we want them to go. Incapacity protection, health for healthcare, financial, making sure that you have the right protections in place to deal with that. For those that have children, guardianships or dependents. Is there a charitable intent? Is that a common objective? And then lastly, tax control. One of the things that, from a personal standpoint, that we dealt with a lot with in working with my dad was just making sure that while living with Parkinson's was a difficult deal, but making sure that the family, that if we can ease any type of burden on them, that we're able to do that. So at the office here, we try to do things like making sure that money can move easily. We like to be in contact with families of those living with Parkinson's, and that's just to help. If we see things like Dr. Malhado was saying, Chang Malhado was saying, behaviors change, and we see it often because we're in constant contact with our clients. And it's sad sometimes we see things happen where either people start spending money aggressively. Amazon's made it very easy to spend money these days. But as behavior changes happen, or with medications, we see clients forget to make payments for things like a long-term care policy. That can happen. And so if you have the right controls in place, it can help with some of those challenges that families face. All right, so a properly designed estate plan has 3 main focuses. One, we're going to want to make sure that we're planning for the expected. 2, we're going to make sure we're planning for the unexpected. And then lastly, we want to make sure we're positioning for both. So planning for the expected just comes down to understanding your current situation, not only from the estate plan side, but also the financial side. We like to spend time really understanding what are the key priorities here and objectives. What are we trying to get done? We encourage transparency to the level of comfort that our clients have so that we can make sure that we're all on the same page. And then lastly, as we're planning for the expected, we want to make sure that we're balancing any goals that might be possibly competing with one another. Planning for the unexpected. Those are things like life events, whether it's with our clients or their beneficiaries, governmental changes in law and tax regulation. And then lastly, so often we'll see estate plans being created and goals set up, but not necessarily implemented correctly, whether it's through account registration, documents, or things like that. And then finally, positioning you for both. So, on the investment side, how and where are we putting the investments? Are they in line with your goals? Are we aware of any potential risks that may be in front of us, and just helping people navigate through that? So like I said, it's a team approach. It's not just financial planning. We lean on your tax professionals and your attorneys to make sure we're getting what you want to get done. One of the things we do in our annual reviews is we make sure that we are looking at the beneficiary designations. Things change in the lives of our beneficiaries. Things change in our lives. Like we may have different feelings or needs or wants. And so and your goals change. So we want to make sure that you're reviewing that on an ongoing basis for potential changes. Let's see here. I already kind of talked about that. So with me is Juliette Robertson. Juliette, when you speak, I would be curious to get your opinion on how often review should be done on the actual estate plan. But anyhow, that's it for me today. Thank you for your time. If you have any questions, be happy to answer them, and hope everybody has a great weekend.
Good morning, everybody. My name is Juliette Robertson. I am an estate planning attorney. I also do estate administration and litigation. So we have a unique perspective on this stuff at our firm. And to answer Mark's question initially, I would say almost as soon as you get that Parkinson's diagnosis, you want to be, assuming you're in the mild cognitive impairment stage, like Dr. Malhado-Chang discussed, you want to make sure that you're into an estate planning office, either getting documents in place or reviewing the ones you currently have so that you understand how they work, when you need to start implementing them, and that you're in control and that you know what they say. So we've got our slides here. I called it estate planning is not just for wealthy people, because there is sort of a misperception that only people with tons of money need to have estate plans. And that is so not true. Like Mark talked about, the state of California does have a default system for planning your affairs if you do not do it for yourself, but most people do not like the default, or it is not in line with their family dynamics, and so they would want to set up a plan to make sure things pass or are legally controlled by the people that they want to have in those positions. So let's just talk about what an estate plan is. An estate plan is instructions from you, and it tells other people what to do when you become incapacitated or at your death, and it also gives other people the legal authority to manage your assets and your healthcare decisions on your behalf. And so we're going to go through the different tools that we use as estate planners to implement those things. First, I want to talk briefly about capacity. Dr. Malhado-Chang touched on this a lot in her presentation. All of us will lose capacity at some point in our lives, either physical capacity or mental capacity. It's just that the degree of that capacity will be different for everybody. And so in the estate planning world, we have different levels or different standards of capacity that we consider when people are able to do things for themselves, whether it be writing a will or a trust, or signing a contract, or making a medical decision. And so the different levels of capacity are different for each one of these things. The highest level capacity is for contractual capacity. That would be for signing a trust, authorizing power of attorney, those types of things. And that's why I mentioned you want to be able to get those things done at the outset of a Parkinson's diagnosis if it's early on in that disease process. Medical decision-making capacity, that is for your doctor to assess. It's whether or not you can understand and give informed consent for the risks and benefits of a particular procedure or for end-of-life decisions, that sort of thing. And then testamentary capacity is the capacity that would be required to sign a will, and we'll go through that in a second. So as far as estate planning documents consist of documents that give legal authority for individuals to manage your affairs and decisions while you are still living, and then documents which instruct the distribution of your estate after you pass. And so in the first category, we've got the healthcare directive and the power of attorney for financial management. These are two powers of attorney documents that would give authority over those same things, healthcare decisions and financial management. The healthcare directive is absolutely necessary. I am the proponent of estate planning. Nobody needs estate planning, they want it. Well, except for this document. Everybody needs this document. This document is instructions to your agent or to healthcare providers regarding your wishes for care, for end-of-life decision-making, for everyday personal care. And it's really important because if you don't have it, the alternative is going to court and being under conservatorship, which modernly people are really afraid of because it's complicated, it's expensive, and it's a lot of court oversight and decision-making. So a healthcare directive gives another person the authority to manage your healthcare instructions and all of your daily needs. They are called your agent, and it's in a particular form. They have all of these authorities on this list. They can make decisions, determine your personal care, what clothes you wear, where you live, what you eat, how much medication you get, whether you authorize hospice, who sees you, what household employees you have, where you get transported, all of your funeral arrangements and remains, so cremation or burial, whether you get autopsied, if you get to donate organs, and it also nominates a conservator of the person if that became necessary. The person on your healthcare directive also has unlimited access to all of your health information under HIPAA. And so it's a really powerful document, and it's really important to consider this. If you have a healthcare directive, you would create this with your estate planning lawyer. They are also available publicly for no charge. I know any Kaiser members have access to the Kaiser form that is available through that healthcare institution. A lot of hospitals also have template healthcare directives that you can obtain. You just want to review them carefully and make sure you understand their terms. And then once you have signed them in compliance with the state laws, which is either with 2 witnesses or with a notary, then you should keep a copy with yourself at all times if you can. Always give a copy to the person that you have named as your primary agent, and then also give a copy to your physician or health system if that is possible. These directives do not become effective until a doctor says you cannot make the decision for yourself. And so it really is your backup contingency plan in case you lose capacity. And it's also really important for spouses to have and caretakers to have for an individual with Parkinson's. If you have executed a healthcare directive outside of the state of California, it is still valid in California as long as it was drafted and executed in compliance with the laws of that state where you signed it. So, and in California, all physicians are legally entitled to presume that a directive executed in another state is valid. So if you move here, or if you've got a directive executed out of state, it's presumed valid. Let's see. Just on a side note, times when I've seen directives not valid is when they are witnessed by disqualified witnesses, such as family members or appointed agents, people that have an interest, or if they're not notarized correctly. I stuck this in here as a side note. When are healthcare directives not used or not able to be used? Well, in an emergency, if your providers don't have any knowledge of your wishes. So this might be, if you have a DNR or you have a POLST or you have a very aggressive directive that says no care, but you're found down somewhere and nobody knows about your directive, they're going to treat you. They're going to treat you to save your life until they are made aware of those directive instructions. And then individuals that are given authority under healthcare directives are not legally authorized or able to commit someone to a mental health institution or to authorize electroconvulsive therapy or sterilization or do an abortion. Those are all things that are absolutely off limits for a healthcare agent to consent to for someone. But one of the things I want to touch on here is that estate planning is voluntary. And so at any point, if someone does go down the path of hallucinations, delusions, becoming sort of paranoid or objecting to the help of the person they have named to make decisions for them, they can unfortunately unwind the process. And so if your loved one is refusing your help or is telling providers that they don't trust you or that you're going to kill them or something to that effect, or if you need at some point to place them in a secured perimeter type facility, you know, like a memory care that's a locked care facility or something like that, and they don't want to be there, they are accusing you of locking them up and they're refusing to stay or whatever, then unfortunately you would have to make the move towards conservatorship, because conservatorship is the only legal way in California that we can force decisions on another person. Let's see. What if you don't have a healthcare directive? Like I said, conservatorship is your option. Some hospital entities will authorize spouse or next of kin to make decisions, but they're usually not the big major decisions. They're usually decisions that will just facilitate the continuation of care. And then sometimes we use judicial authorization for a specific type of surgery. For example, let's say that there's a heart condition or a heart surgery that needs to be performed, and there's not a lot of time. We can get court authority to do that surgery, but then after the fact, we would have to pursue some sort of general conservatorship for ongoing needs. But the healthcare directive is still the gold standard for authorizing someone else to make decisions for you. So a little bit about conservatorship. Conservatorship is this process in California. We have it available for matters of the person, so caregiving matters, and then also matters of the estate for someone that doesn't have powers of attorney in place, or a trust, or estate management authority in some respects. And it's somebody being appointed by the court, usually a family member or a friend or a professional fiduciary, to manage another person's health, food, shelter, etc., or money. And they have all of the powers that they would need to make medical decisions or financial decisions. They would not have the authority to remove life-sustaining treatment. And so this is a huge issue with conservatorship as an incomplete plan for anyone, because in the state of California, the default is to save life and to preserve life. And so a person under conservatorship who does not also have a healthcare directive instructing removal or withdrawal of care at some point when care is futile would have to stay on life support. And this is a huge conflict with care professionals. So the healthcare directive is so important. Even if you have to go into conservatorship because your loved one is refusing assistance, the evidence that that healthcare directive was once signed and expresses their intent that they be allowed to pass naturally or to be removed from life-sustaining treatment is so important, because it will give the conservator the authority to act on those instructions. Power of attorney for financial management. So we talked about power of attorney for healthcare management, which is also called the healthcare directive. Power of attorney for financial management is a similar concept, but it has different varieties. But in general, you are giving another person the authority to make financial decisions for you regarding all of your non-trust assets. So it assumes that if you have a trust, your trust terms would control those decisions. But for non-trust assets, you're giving someone else the decision and the authority to make decisions for you with respect to financial management. And we have different types of power of attorney. There is a durable power of attorney, which is immediately effective and stays in place regardless of subsequent incapacity. This is really the best kind of power of attorney to get these days. And I'll tell you why in a second. Springing power of attorney is another type, which is effective only upon incapacity, has all the same authorities that a durable would, but it those authorities do not become effective until someone has been formally declared incapable of making financial decisions for themselves from their physician. There's also limited power of attorney we don't see too often, but it would be for a specific transaction. And then general power of attorney you sometimes see, which is a statutory form with check boxes, which is fine, but it's not a very specific power of attorney, and sometimes banks won't give you won't let you use it for certain things that aren't spelled out perfectly. And so back to this whole durable springing power of attorney thing. Modernly, banks are refusing to accept springing powers of attorney. They don't want to have to determine if one of their clients is incapacitated or not. So I strongly recommend that if you already have power of attorney in place and it is a springing power of attorney, you should revise out of that into a durable and immediately effective power of attorney. It is the only way to ensure that you are not going to have those hiccups when you go to use the power of attorney. And then you may be thrown into conservatorship involuntarily. Let's see. Some examples of the authorities that are granted in a power of attorney are, the ability to access and use bank accounts and credit cards, file and defend income tax returns, hire attorneys, CPAs, financial advisors, manage and reposition your investments, pay and negotiate bills, settle and file lawsuits on your behalf, buy and sell real estate, control and receive all mail. So these are some basic powers that would be included in a financial power of attorney for someone else. And you can see how these would be really important things to be able to do for someone if they could not do that for themselves. And also for married couples, it's really essential that a spouse have these authorities. If they are in the, if they are, everything is joint and they would want to have seamless transition of management of their assets with a with their spouse suffering from a Parkinson's type condition or decline of capacity. And then, I stuck this in here. If you want any of these powers to be included in a power of attorney, they need to be expressly indicated. And these are the types of things that we do when we are thinking that someone might be a candidate for Medi-Cal in the future, or if you are thinking about doing Medi-Cal planning to move assets around to qualify for our state welfare for long-term care. And so it's things like the ability to create or modify a trust, revoke gifts, disclaiming assets, changing beneficiary interests, changing PODs. These are really enhanced powers that give your power of attorney a lot of authority, and a lot of clients really think twice about these, but they would have to be expressly included to be for the person to be legally authorized to handle them. And then who should have a copy of your power of attorney? This one's a little bit different. You want to keep this one close to the vest. You want to provide it only to the person that is authorized to make decisions for you if you do trust them to not act prematurely. You do, however, want to inform your agents that they've been nominated so that if something did happen, they would know that they were going to be called upon to make those decisions. Let him or her know where you keep your important papers. If your attorney keeps copies of your estate plan, that's always a resource as well. And just make sure you trust these folks that you're putting in these legal authorities to manage for you or your spouse. And then how does a power of attorney terminate? So a lot of people think that power of attorney continues after you die, and it does not. Power of attorney is only effective while you're living. And so it can terminate by death. It can also terminate by the person who created it actually revoking it and giving notice to the person with the authority. You can remove your agent and contingents. They can resign, and then you have no one in place. There are lots of different reasons why a power of attorney would terminate, but they don't go on forever and ever. And then again, similar thing, if you have an out-of-state power of attorney and you're living in a different state, it should be valid, but just to be careful, because banks make their own rules these days, I would absolutely consider getting one drafted in the state where you are currently living and intend to transact your financial business. So what if you don't have valid power of attorney? Again, conservatorship of the estate may be required. Even if your spouses, banks and third parties, title companies, realtors, all these third-party agencies, Social Security Administration, that are in control of transferring assets, titling of assets. They tend to make their own rules. And so if they may not acknowledge a spouse's authority to handle on a joint account or something. And so you would need to go to conservatorship for these types of things. Conservatorship is not fun. It is complicated. It is expensive. It is time consuming. It's a lot of, it can be invading of your privacy. So doing a basic estate plan, which really doesn't cost too much money or shouldn't cost too much money, is the best way to potentially prevent the need to go to court for conservatorship. And then for folks that only have Social Security benefits, like for Social Security retirement or disability Social Security, there is a process internally within the Social Security Administration where you can get authorized as a representative payee to manage those benefits and be overseen by the Social Security Administration. That's kind of a standalone option. Who's appropriate as an agent for a healthcare directive or power of attorney? Obviously, somebody that you trust to care about your best interests. Sometimes beneficiaries of your estate can be in a conflict of interest. It's not untrue that somebody might hurry care or give you less expensive care if they were the intended beneficiary of your estate. It's a very cynical position to take or observation to make, but I have seen it in my practice on occasion. There are licensed professional third parties that are becoming more and more well-known and needed in our communities. If you do not have people after, your spouse or a child to step in if something did happen. And it doesn't necessarily have to be somebody who's living or working close by to you if they are able to respond and address things remotely. With the pandemic, a lot of these technologies have been seriously improved, and to be able to communicate with a bank or with a healthcare provider over Zoom or text or any types of these online communication systems has really improved the ability for people that don't live near you to act in these positions. And then lastly, what happens to how do you distribute your estate after you die? And that would be a will or a trust. And so we're running a little bit long, so I'm going to go through this a little bit quickly. A will is a document that describes who gets what after you die. A trust is a contract between you and yourselves regarding how your assets pass at your death. A trust will help avoid probate. Probate is the process that oversees the administration of wills. So if you have a trust, you avoid probate. If you don't have a trust, your will would go through probate if your estate amounted to more than $166,000 in California. Other states have different thresholds for that. But let me just skip here. This is some real technical stuff. There are ways to pass your assets at your death without the need for a will or trust, and those are called non-testamentary transfers. These are things you'll want to check in on if you do get a diagnosis of a medical condition that would affect capacity and that sort of thing. And so these are, you always want to make sure you have beneficiaries on any IRA accounts. You want to make sure that your bank accounts have pay on death beneficiaries. Annuities require beneficiaries. Life insurance requires beneficiaries. So if you have beneficiaries on all of your financial interests, those assets would pass to those beneficiaries without the need for a will or a trust. Let's see. Reviewing your estate plan, how often? As often as you want. If an attorney puts a recommendation in there, like you need to come in every 2 years or 3 years or 5 years or whatever, it's usually some sort of a money generating recommendation that helps them keep their practice going and you paying them money to create documents. But honestly, if you've executed your estate planning in the last 10 years, you're probably okay. In the last 20 years, you probably still want to have it looked at because there were some major tax changes in 2010 that affected estates. And you want to make sure that your planning has a lot of contingencies built into it so that if people did pass or become ill or disabled or your trustees no longer wanted to be serving or they are incapacitated themselves, you have options that you don't need to rush into an attorney and update before you die. And then on the death of a spouse, some administration may be necessary. So you definitely want to see an attorney on the death of a spouse. Let's see. So should you consult an attorney at all about this stuff? Well, I'm self-interested because I do this for a living, but yes, no, it's very important. These are complicated documents. the stuff I've seen people bring in from LegalZoom and from, Susie Orman and that sort of thing, they're usually fraught with issues that the client wasn't aware of that would trigger some sort of litigation or shortfall. You want to work with somebody that has legal malpractice insurance in case there are errors made or something wasn't accounted for. Don't be lured by extremely discounted estate planning. Be vigilant about upselling. There are a lot of attorney offices out there who will sell you everything that they can. Legal advice should not be about sales, everybody. It should be about making legal recommendations, explaining those recommendations, understand your options, and then making a choice and going with that plan. It shouldn't be about, well, it's been 3 years since your last plan. You're going to have to redo all of this because that's our policy. That's not okay. But you do need to work with an attorney to get the review and analysis that you need. And who do you go to? Friends and family who are satisfied with their attorneys, get recommendations. Your financial advisors like Mr. Schumacher and your bankers and CPAs usually know people they've worked with that are really competent and helpful. Meet with somebody who has an actual office where they can meet you. We all have our bar licenses through the state of California. Make sure they're a lawyer that's licensed, and don't hesitate to interview more than one person. Because this is an important choice, and hopefully it's somebody that stays in a relationship with you for the rest of your lives. And that's the end of my topic. I look forward to questions. And if you did want to ask me any follow-up questions outside of this webinar, you're welcome to send me an email or contact my office. Thank you.
Great, thank you so much. I'm going to have all the speakers jump back on screen if we can spotlight everybody here. Okay, fantastic. Well, thank you, everyone. I want to, acknowledge that is a lot of information. I also want to just let everyone know who's in here. As a personal note, I have a family member with Parkinson's, and I just went through all this with the power of attorneys and everything. And I can tell you all from personal experience, the time to think about it isn't while you're going through it. That was hard. It was hard for me. I was made a medical power of attorney, and I did not know what I was doing at all. And so I just want to encourage you. I know it's a lot of information. I know it's a lot to think about and to process, but I would just encourage everybody to find somebody that you trust to work this out ahead of time, particularly before the person has any cognitive decline or any sort of issues, because these things are very helpful. Your advanced healthcare directive, I'm just going to point out a few before we jump in. The advanced healthcare directive, this helps you outline your wishes and tells you, right, your power of attorney, medical power of attorney right here. You might also have this form. This is called Physician's Order for Life-Sustaining Treatment. So this can help too, having that will. So those are your big pieces that, I would encourage everybody to talk about now before you need it. Okay, so let's jump into a question for Dr. Malhado-Chang. I thought this was a fantastic question. Somebody wrote in to ask about extreme anxiety during off periods, but it wasn't the person with Parkinson's. They said it was the care partner who was having extreme anxiety during these off periods. Can you talk about that at all and any suggestions you have?
Oh gosh, what a great question. So I think that really just speaks to the fact that it's not just one person going through Parkinson's, right? It's the care person is affected just as much as the patient. And so off-period anxiety, similar to off-period motor symptoms, are really treated by an adjustment in the Parkinson medications to try and avoid those offs. And those offs are as debilitating to the care partner too. So if we can make one's dopaminergic stimulation more constant so that you're not on that roller coaster of ons and offs, that helps everyone.
Thank you very much. Again, finding a little bit of maybe prevention, right? Then that would really helpful. Okay. Dr. Malhado-Chang, we had a question, and I think it was from Melissa, but I'm going to ask you because this is a good one too. They were asking why power moves and exercises tend to be very exaggerated and big in Parkinson's. Can you answer that one?
Sure. Yeah, absolutely. We want them to be as big and exaggerated as possible. And Melissa did a wonderful job of that. What happens in Parkinson's is our movements become stiff, slow, and small, right? So our steps get very short and shuffling. Our handwriting gets small. And in order to combat that, the exercise is focused on exaggerated big movements. So if you ever see LSVT big or PWR, one of these Parkinson exercise programs in action, you'll see the steps being huge and pretending like you're in a marching band and pretending like you're lunging forward to walk instead of taking those short steps. So that's what we want to do with Parkinson's exercises. We want to do the opposite of what Parkinson's wants, would create as our default movement, and make really large amplitude movements. Specifically, I'll also just mention that is one of the reasons why things like stationary bicycle and boxing are popular, because the bicycle creates repetition of those large amplitude leg movements, just as boxing takes advantage of those large amplitude arm movements. So that's one of the reasons, and our research supports that those particular exercises are neuroprotective in Parkinson's.
Makes a lot of sense. Thank you so much for answering that. Because sometimes it feels a little, maybe even silly, but it's important, right? So
it is. It's important because it delays the disease.
Yeah.
It slows down the progression of the disease.
Great, thank you. Mark and Juliette, can you explain a little bit about medical power of attorney versus healthcare proxy? Can you tell us the difference?
It's all you, Juliette.
Yeah, there really isn't a difference. Healthcare, in the healthcare industry, so like when the doctors are trying to help somebody, they're looking for what they call the surrogate. And so the surrogate is going to be the person with the legal authority to make decisions for someone. And so healthcare proxy and healthcare power of attorney are the same person. They're the person who is authorized to act in place of the person without capacity. What you may hear is a healthcare power of attorney and a living will are sometimes separated. The living will is the instructions for end of life care or care period, where you would want to be provided care, what level of care, what happens if you are in a coma, what happens if you are incurable and terminal, what happens if you get advanced dementia and don't recognize anyone anymore. I mean, these are things that are incorporated. The healthcare directive in California is both of those things merged into one document. It's giving someone the authority or the power of attorney and giving them the instructions about how to do that job. And then so healthcare proxy is really the same concept. Proxy is a word more used for stock options and things like that, right, Mark? When you are a shareholder of something and they're making a big shareholder vote and you give some person proxy to make your to vote for you in that context. So it's the same concept in healthcare where you're giving someone else the authority to make healthcare decisions on your behalf. And so the healthcare directive in California is both of those concepts merged. It's the authority or the proxy, and then also the directive or the instructions for the end of life wishes.
Oh, that's great. I asked because in my own case, we had not signed the power of attorney before. And so then it became a proxy. So I think, again, it just stresses the importance of signing those as soon as you can and getting your information in order sooner.
Yeah, no, I've got clients that come in as soon as they're diagnosed with some sort of a dementia, and that's great. That empowers them to get it done and to have it in place and just know it's there for when things really start going downhill, if they are going to go downhill. But then, they also come in and make changes, and then we check in every time they make changes to make sure they still have that requisite capacity to make those changes. But they're being more self-aware and being more proactive is the best way to empower yourself in this process, because the scrambling that comes when, oh my God, we didn't get around to this, we didn't plan, and now we're in this position, and how do we scrape together something that is 100 times more stressful than actually getting the plan in place in the first place. And so to avoid that stress and that urgency is to empower yourself to be prepared and to be ready, even if you may never even have to use it. You know, your loved one could retain enough capacity throughout the rest of their life with Parkinson's and never need to act on that power of attorney or act on those healthcare directives. But knowing it's there is a comfort in of itself.
Right. Thank you. Thanks for that. And then Mark, so the financial side, I mean, we think a lot about, you know, how are we going to make sure we have everything we need if the disease does progress or when it does progress, or for, you know, planning for later long-term care and so forth. How do all these things work together? And sort of what's your like maybe top 3 suggestions on the financial planning side?
The progression of Parkinson's is different for everybody. And so the needs, whether it's financial or physical needs, they vary. And so I think from a planning standpoint, the biggest thing is just to build a plan that you can. We use software to build in, you know, future expenses and things like that. But you know, having a community around you that has gone through this from a financial, from a healthcare, from just a support level. I mean, I think that's huge. But some of the just common things that we immediately start thinking about is, do we need to have money available for transportation or home modifications for those that want to be at home? And then when somebody does have long-term care insurance, we want to make sure that that stays in force and that doesn't lapse because of lack of payment. So making sure that families are listed on it and just reviewing that. And then the last thing I just will throw in there is people who have Parkinson's or cognitive issues, they are subjected to scammers. And so for the families that are on here, just the more involved people can be. Finances are weird, you know, there are generations that they just don't talk about finances. It's changing, but just the more communication to catch. I mean, I hate to say it, but every year I hear a story of somebody getting scammed, and it is avoidable through having people involved. And it's to the level of comfort that the client is willing to do.
And I've seen where, you know, estate planning that builds in a lot of flexibility for powers of attorney can help somebody out of a jam, can help somebody access resources for care and for, Medi-Cal or in-home support services or whatever. And because that power of attorney was in place, someone else can do that on behalf of somebody, and that complements the financial planning. So even for people that don't have a huge portfolio or portfolio that allows them to be self-insured for memory care or something like that, having power in place to another person to be able to situate resources and access other public resources is also a huge part of that plan.
One other thing I'll add is we are able to add what's called a trusted contact to a relationship, where we have the ability to reach out to whoever that contact is. We don't share any account information, so that's all remained very confidential. But the conversation can be something along the lines of, you know, hey, I spoke to mom and dad, or spoke to mom or spoke to dad. I'm a little worried about them. You know, I think you should check in on them. And that at least gets the family, us legally able to say, hey, something's not right. We talk to our clients at least 4 times a year, so we see when something is different. And just being able to do that is helpful.
No, that's great. The theme of the day, let's talk about it. It's not easy. I just want to acknowledge that again. This isn't easy, but it's important. And so thank you all for staying a little bit after to get some of these questions answered. And thank you to our speakers, Dr. Malhado-Chang, Mark Schumacher, and Juliette Robertson. Again, we shared the information in the chat. We'll share everything again after, because I know, you want to process it and sort of look through everything. If you submitted a question and it didn't get answered, please know that we're here for you. Call our helpline. email us, call me, email me, and we'll get you to the right person. We'll follow up with your questions. You have also great resources in Sacramento as well. So we're going to have a survey after this. So we'd love to have your feedback. We also want to thank Melissa. I know she had to drop off, and Boston Scientific and Abbott. Thank you for attending. Again, reach out to our helpline. Let us know if you have any questions. And we thank you for joining us. And goodbye, everyone. Stay safe.